Okay, good evening, everyone. My name is Rupa Brasso. I'm the SVS Foundation's Executive Director, as well as the Senior Director on the SVS side overseeing industry relations. Thank you all so much for taking time out of your busy schedules to be here with us tonight. The SVS and SVS Foundation are accomplishing amazing things to accelerate and advance vascular patient care in the US and around the world. And we are working tirelessly on behalf of our member surgeons, PAs, and nurses to position them to deliver optimal care. We simply could not accomplish this amazing work without your support. So we thank you for your support through the years and being a part of the SVS and SVS Foundation. I wanted to take a moment to let everyone know that we will be recording today's session. We will start first with the state of the SVS, then move on to advocacy and education. We brought the full complement of volunteer and staff leaders from the SVS to this town hall today for your benefit to learn more about specifics on what we have been able to achieve with your support and a short look on where we would like to head. We will have an opportunity to ask questions at the end of this town hall. Before we get started with this program, I wanted to take a moment to say thank you for your support. This is an exclusive member benefit of the platinum, gold, and silver level and above, and we are grateful to have you here today and grateful for your support. We do not get enough chances to say thank you, so thank you again, and I want to make sure you know that you're a valuable member partner and that your contributions are very much appreciated. With that, I would like to now turn the program over to Dr. Joe Mills, who's the SVS President-elect and Chairman of the SVS Strategic Board of Directors. Dr. Mills?
Thank you, Rupa. I especially want to personally thank our corporate sponsors who are with us tonight. The SVS builds its program profile and initiatives around a strategic plan, which we review and refresh annually each January through the Strategic Board of Directors. The SVS Strategic Plan is organized into 6 domains, as you see here, each of which has directional objectives. I'm going to focus on the research, practice, and quality sections, as you will be hearing from experts in advocacy and education shortly, and Ken or Mike will take you through the organizational health of the SVS. So every 3 years, the SVS surveys its members to assess key trends and priorities for organizational-wide focus. Here are the results of the survey from 2019 to 2020. And these top priorities have guided the SVS for the past 3 years. And you can see the top few include advocacy and public policy, branding of the specialty, quality and appropriateness, and optimization of future vascular care models. Great progress has been made in every one of these areas, but in many cases, we couldn't have achieved success without your support. The next survey will be going out to our members on November 2nd. Next slide. So there are too many examples to name them all, but a few worthy ones include going from left to right. We have a portfolio of work that included an SVS DEI initiative, including a JVS supplement put together by many of our diverse members. We've created educational resources and disparities research. We're trying to broadly disseminate and translate clinical practice guidelines and appropriateness of care guidelines into clinical practice. We have focused on physician wellness, including coaching and mentoring and support. We've tried to better define practice characteristics and support people in our society who work in community practice, and particularly in OBLs. And we have a robust leadership program. We think that leadership in vascular surgery research is part of our DNA, and the SVS has become synonymous with producing and creating a platform presenting the highest quality, most current and cutting edge research. Our primary focus in the last 3 years of research has been to forecast and guide the next 10-year horizon by publishing a top 10 list, which you see here. We also want to support vascular surgery as a career choice and endeavor for early career vascular surgeons, and expand and improve the VRIC conference focused on breakthrough research in vascular disease. The SVS is considering options to support an innovation incubator to help members accelerate development and testing of new medical devices and ideas. Another of our major focuses has been on quality of care and we hope to serve as an epicenter of quality improvement and research in vascular surgery. The JVS just published its first ever appropriate use criteria on claudication in 2002, and will soon begin work on the next one to be focused on carotid disease. We have also been working regularly with the American College of Surgeons to launch a Vascular Center of Excellence program to start in 2023. The SVS will publish a comprehensive primer on conducting quality initiatives in practice in 2023. And we have established an OBL quality improvement research initiative focused specifically on delivering care in the OBL setting and assuring quality. We think that the SVS PSO and VQI Vascular Quality Initiative is a jewel of real-world evidence registries in vascular and continues to gain prominence. And in fact, recently, more than 1 million patients have been enrolled in this registry. The SVS is convening a quality improvement summit in 2023 to plan priorities for the next 3 to 5 years. There we go. One area that concerns us, if we want to consider to be the epicenter of quality, is to strengthen practice models so that they are not undermined in their ability to achieve quality outcomes. To that end, the SVS formed a section on community practice and a subsection of OBL practice to strengthen practice management education and practices to help optimize efficiency of care. As we briefly mentioned, clinical practice guidelines can only be optimized if they're broadly disseminated, and a major effort is underway to expand in the distribution of these clinical practice guidelines. We all know that physician burnout and wellness are well documented among all physicians, but including vascular surgeons, and the SVS is trying to lead the way with original research and programs to support vascular surgeons in practice. We don't know enough about the demographics and characteristics of evolving practice models, so we are undertaking research initiatives to gather this information to be used for planning. And finally, we think the biggest threat to quality and practice in our specialty is declining payment from Medicare, and this is a major focus for our society. You will hear more about this from Dr. Seidemann. Thank you for your time, and at this point, I'd like to turn it over to our president, Dr. Mike Dawson, to talk about some of the priorities for our society as a whole. Thank you.
Thanks, Joe. Based on actually some input from you, our industrial partners, SVS advocacy and education are really going to be the highlights of tonight's discussion. And we're certainly made some major investments to strengthen that infrastructure throughout the last years. And we're very proud of the results of our strategic direction and growth in these areas. At this time, I'd like to highlight 3 additional areas we've made significant efforts to support and strengthen. We actively support early career vascular surgeons as demonstrated by the establishment of a Young Surgeons section, which will allow members to work on projects of particular interest to their early career development. It provides for early leadership opportunities and engagement in a meaningful way to push vascular surgery forward, which they all desire to do. We have supported a cross-organizational strategy for branding vascular surgery medical students and residents through COVERS, and this stands for Coalition for Optimization of Vascular Surgery Trainees and Students, which provides information on local vascular interest groups, residency programs, career checklists, links to important resources, and ways to interact with colleagues and like-minded students. We strive to find and recruit the best students to our specialty and to improve our workforce in a meaningful manner. We also support vascular surgery interest groups at local hospitals to keep students engaged in real time. As a reminder, SVS provides management support for the Association of Program Directors in Vascular Surgery and has a close relationship with all other vascular societies to help each support our youngest members or potential members. Diversity, equity, and inclusion has been a major focus and area of investment for SVS on many levels. We are developing a DEI module with an expert consultant to help our leaders understand how to transform and advance our DEI culture. We have formed a DEI committee to provide insight into both educational and governance opportunities to have more voices at the table in everything that we do. We have established a women's section to provide insight into the challenges and opportunities that affect women in a vascular surgical career. We are convening all vascular societies into a series of summits to advance and translate DEI principles and core values vascular surgery wide. Our goal is to have these values and principles embedded in our very culture. SVS has substantially invested in and evolved its communications infrastructure with a new communications committee leading the way. It is anticipated that this area will continue to evolve very rapidly with new practices in web development, social media, and video production. Communication is critical to member engagement, education, and feeling of empowerment on many levels. It allows us to meet our members where they live and interact. Finally, we have seen a resurgence in the interest of vascular surgeons around the globe to connect and share best practices. The SVS has now become the seat of administration for the World Federation for Vascular Surgery and has a strong international committee which is leading that effort on many fronts. It is now my pleasure to turn the presentation over to Dr. Matthew Seidemann and Megan Marchenko to bring you up to speed on SVS advocacy.
Good evening. My name is Matthew Seidemann. I'm the chair of the SVS Advocacy Council. In that role, I help facilitate the communication and coordination among the SVS entities involved in health policy and advocacy. Our approach to advocacy is based on three core pillars for engagement. The first being legislative and regulatory advocacy, the second political advocacy, and the third is grassroots. For us to be effective in these areas, the SVS remains active both independently and via extensive coalition networking. Throughout this year, the SVS has been expanding and establishing new programs designed to strengthen engagement among SVS members and to increase our footprint in these three critical areas related to our advocacy activities. Our goal is to maintain cohesive advocacy programs where each pillar is complementary to the next as our opportunities for success increase exponentially when each of these gears is in motion. Next slide, please. So our activities over the last several years have been driven by several key priorities. First and foremost, we continue to focus on efforts to mitigate payment reductions generated within the Medicare physician fee schedule. Fundamental flaws within the fee schedule, such as budget neutrality and the lack of an inflationary update, continue to compress payments for physicians. These annual cuts and the general lack of financial stability for physicians have created an unsustainable scenario. Left unresolved, we see that these changes will lead to significant patient care access issues. In addition to our work to secure short-term mitigation of these payment cuts, we are also engaging lawmakers and those within the administration regarding the need for long-term systemic reform to the Medicare payment system. Addressing administrative burden for physicians is another key priority. The SVS continues to support legislation designed to reform current prior authorization processes under Medicare Advantage plans to improve access to medically necessary vascular care and reduce the burdens that restrictive prior authorization policies impose on all physicians. In terms of workforce, we have a two-pronged approach, pursuing an expansion of funding for graduate medical education to ensure a robust pipeline of surgeons for the future, while also working to protect and support surgeons of today via programs focused on physician wellness and reducing burnout. Finally, the SVS continues to track initiatives related to public health. Next slide. While there's still significant work to be done, we've seen some positive momentum regarding the aforementioned policies. In the payment space, the SVS played a critical role in securing the inclusion of provisions in the 2020 and 2021 year-end legislative packages to mitigate scheduled Medicare physician payment cuts. In each of these years, the year-end activity was driven by extensive bipartisan and bicameral support for the relief efforts, which was generated by SVS and its coalition partners. In terms of this year, we've already secured introduction of the legislation, which is HR 8800, to provide a 4.42% positive adjustment to the Medicare conversion factor for 2023. On the other side of the Capitol, Senators Stabenow and Barrasso are circulating a letter highlighting the importance of addressing the payment cuts before the end of the year. Another significant victory was the passage of the Lorna Breen Healthcare Provider Protection Act, signed into law in March. This important legislation provides federal funding for mental health education and awareness campaigns aimed at protecting the well-being of healthcare workers. The goal of the Dr. Lorna Breen Healthcare Provider Protection Act is to prevent suicide, alleviate mental health conditions and substance use disorders, and combat the stigma associated with seeking help. It provides up to $135 million over 3 years to improve mental health and resiliency and train medical students, residents, nurses, and other professionals in evidence-based mental and substance use disorder strategies. The SVS was proud to support passage of this important legislation and hopes that it is the first of many programs designed to promote overall physician wellness. Another area of effective coalition work to drive bipartisan success relates to prior authorization relief legislation. Since the bill was first introduced, the SVS and our coalition partners have secured more than 300 bipartisan co-sponsors for the Improving Seniors Timely Access to Care Act. If enacted, the bill would create an electronic prior authorization program that adheres to federally developed standards. It improves transparency by requiring plans to report to CMS on the extent of their use of prior authorization and the rates of approvals or denials. It requires plans to adopt transparent prior authorization programs that are reviewed annually, adhere to evidence-based medical guidelines, and include continuity of care for individuals transitioning between coverage policies to minimize any disruption in care. And it holds plans accountable for making timely prior authorization determinations and providing rationales for denials. The SVS was pleased by the House passage of the bill in September and is engaging key stakeholders in the Senate to continue this momentum. Next slide. In addition to these updates regarding SVS priorities and real-time advocacy activities, I wanted to briefly highlight some positive internal changes for SVS. This is the significant investment in the infrastructure that Dr. Dalsing was talking about. In April, the SVS welcomed Megan Marcinko as our new full-time advocacy director. Megan has an extensive background in the medical specialty community that has enabled her to hit the ground running here at SVS. Our advocacy team was further strengthened by the addition of Andrew Kinney as our advocacy coordinator, who came on board in August. On the heels of these hires, we've seen growth across all of our advocacy programs with plans for more exciting improvements underway. Two areas worth noting are an extensive update of our advocacy website and a successful inaugural Advocacy Week of Action, which is a series of virtual engagement activities for SVS members during the last week of September. Finally, the SVS is striving to identify and cultivate our advocacy leadership of the future via our new advocacy leadership program. We welcomed our first cohort of the ALP following the VAM and are working to ensure that this special group receives targeted training in each of the SVS's core advocacy pillars. Next slide, thanks. Given that I've covered quite a bit of information in a short period, I want to close by circling back to our core pillars. The SVS will continue to strengthen our programmatic opportunities in each of these areas and encourage our members to engage in each element that drives truly effective advocacy. With that, I will hand the speaking role over to Dr. Harris to discuss our education programs.
Good evening, everyone. My name is Linda Harris, and I'm the chair of the Education Council. We're excited to discuss the educational efforts that the SVS has with you tonight. So before we start going into the rest of the presentation, I want to take a moment to set the stage on what SVS is today and where we're going to go in the future. Well, what we are right now is at a high level, we're concentrated at our national meeting, or the VAM, which occurs once a year. The primary learner has been the mid-career academic surgeon, and this has been an important driver for membership as well as revenue for the organization. Education is created by us, and we don't endorse other educational content at this point in time. Why it matters is the SVS plays a critical role in that we provide the most innovative advances in vascular surgery that also meet the MOC and MOL requirements for our domestic members. Although highlighted somewhat in this slide, the forthcoming presentation will highlight where we see the SVS education going in the future because there are changes. Next slide, please. Here's the SVS priorities for the next 12 months. The VAM, of course, will remain our premier project of the year. It's packed with educational content, both didactic and hands-on. We do have 4 live educational programs this year: the Vascular Research Initiative Conference, otherwise known as VRIC, Vascular Surgery Coding Workshop, the Complex Peripheral Vascular Interventional Skills Workshop, and the Leadership Development course. We also have now online education. We've moved, based on our member survey, to a monthly virtual meetings. We have micro-learning sessions, which we've begun, personalized learning, as well as self-assessment opportunities. And of course, we have SVS CME programs as well. Next slide. So as part of our fiscal year 2022 strategic goals, the Education Council conducted an educational needs assessment of all of our membership and the vascular community as well. The survey received over 700 responses from both members and non-members. Next slide. You can see that we actually had a great response overall from all types of members and even from non-members, which was an intentional targeting process. 60% are active SVS members, with 15% being current candidates for the membership, and international and affiliate members also reflect our general membership numbers. Next slide. We asked the learners what their primary source for vascular focused education was, and we were quite thrilled to find out that 86% indicated that the SVS was their primary source for education. We went a step further and looked at the forms of education being used. We found that there was nearly 50-50 split between online and in-person education. This does set us apart a little bit from some of the other opportunities and what interface learners use. For example, the American College of Surgeons has heavy online usage, while regional vascular societies and VEITH are primarily in-person only type experiences. Next slide. We then asked learners about preferences about educational formats and topics. What we learned is that 2/3 of our learners want to return to in-person learning. And we were actually quite surprised that it was the younger learners who responded this way, so those under 40 who we expected to prefer more of the online. Whatever we offer, time commitment is critical, and that's something that's become more apparent after the pandemic. Learners want personalized and condensed learning experiences. For online options, they want SVS to offer webinars once a month, which we're moving towards in 2023, rather than having too frequent or too infrequent learning opportunities. They want on-demand content to watch when they want it and how they want it. In person, we need to keep the offering contents in forums like the VAM, Leadership Development Program, and our upcoming hands-on CPVI workshop. Next. We asked learners about their top areas of need, and this is a list of clinical and non-clinical areas. So these are the areas that we're going to be focusing on. The data is now being used when we review proposals for the VAM for some of the programmatic aspects and also our webinar series. And the goal is to try to fill the gaps in our portfolio. Next slide. Next, we're going to talk through the SVS educational accomplishments thus far in 2022, our plans for the remaining part of 2022 and the first quarter of 2023, and potentially some opportunities for collaboration. As you may know, the SVS offers a diverse spectrum of educational programs, including research in vascular disease, leadership development, coding reimbursement, hands-on skills courses, and programs targeted to vascular surgery program directors and residents. Next slide. The VAM attendance is impressive, even with the pandemic still being a concern. The VQI and Society for Vascular Nursing also met at the VAM, which added to the overall members taking advantage of the VAM experience. 43 countries were represented at this year's VAM, which is an increase of 15 over 2021. Next slide. Data shows that the overall satisfaction from attendees increased from 2021 to 2022, with 91.2% of attendees stating the overall experience was good to excellent. This year, we enhanced the meeting experience in the following ways. We streamed all the plenary sessions. We held 2 additional plenaries on Saturday. We tried 2 innovative formats in the PGE sessions, which I'll talk about in a moment, and expanded the number of section meetings as well. We implemented visual abstracts this year leading up to the meeting to increase the excitement about the upcoming meeting, and we're going to expand this for the upcoming 2023 VAM. We launched the recordings of all sessions during the meeting so people could actually watch them in close time to real if they did not attend a session. And we made improvements to the app and the website. Next slide. Here are some of the ways we've partnered with the industry in the past to support the VAM: sponsorship and exhibiting opportunities, educational grants for CME, support for our residents and student programs, and networking and social activities. Next slide. Now I'm going to highlight some of our other educational offerings, starting with the Leadership Development Program. We've just launched our 4th Leadership Development Program this October. The program is geared towards US and Canadian vascular surgeons between 5 and 10 years out of training. The SVS program utilizes a research and behavior practice-based approach developed by James Coos and Barry Posner. It's a 7 to 8 month blended learning program beginning this month. We've started to conduct research in addition around the long-term outcomes of the program. So in addition to what we do, we like to assess and make sure that we're being effective in our programs. We're looking into how cohort members implement the tools and skills they've learned during the program once they've completed it. Next slide. The VRIC is an exciting experience for our basic science members and members-to-be. This takes place each year in connection with the American Heart Association's Vascular Discovery Meeting. The last one was held in May of 2022 in Seattle, and the next year's program will be in May in Boston. Total attendance is around 100 attendees, and it's focused on investigators, researchers, and scientists. The program's not just about research, but how to translate that research into practice. It's designed to stimulate interest in research among the participants and allow for networking as well as a fun exchange of ideas and growth in the research. Next slide. We just had our coding workshop in October. This program is geared towards not only physicians, but coders as well, and teaches the fundamentals as well as coding that's specific to vascular surgery. It's always sold out, and this year we actually had a wait list. We continue to look for additional ways to provide coding education year-round as well as an online type of format. Next slide. SVS will be conducting its first standalone hands-on workshop this coming weekend. The workshop is on complex peripheral vascular interventional skills. It's split into 2 days, with the first day being purely didactic and case-based learning, and the second day will be completely hands-on. There are 18 faculty, and we're planning on roughly 75 attendees. Current registration is at 70. Next slide. Along with our in-person educational opportunities, SVS continues to expand our online offerings. We repurpose content from the VAM and other in-person meetings. We develop webinars, videos, and microlearning. We're enhancing our self-assessment with BSAP. We're working on the next edition of that currently. And there's general support of the SVS online infrastructure and content development. SVS just held a retreat this past month about online education with the needs assessment data in hand, and this will redesign how we deliver online education to our learners. One of the major things that have come out of this is that we're looking for more micro-learning opportunities for people. Next slide. Outside of the VAM, there are many ways to partner with the SVS on programming, both for CME and not for CME. Some opportunities are included in this slide, and I'll leave this slide up for our discussion. Thank you very much for your interest in the SVS educational efforts. We hope you can partner with us in the future to move forward in exciting directions. Thank you.
Thank you, Dr. Harris, and thank you to all of our presenters today. That was fantastic information. We would now like to open up the floor to our Q&A portion. Please use the Q&A button at the bottom of your screen to type in your questions.
I think while we're waiting for the questions, I would like to say that our leadership and advocacy development courses have really put an energy into members that were interested in this field, and it really kind of positions us to have people to come up and be involved with this society much more with much more knowledge and with a wider range of ability to be involved. So I think those are great. There is a question. It says, what can we do to support the women's and young surgeons sections? It comes from Catherine Lampy. I think there's actually a lot of opportunities for that. I'll take a little shot at this first and then kind of open it up to other members, Joe or Ken. But it's really it's an exciting opportunity for especially the young surgeons to be involved, because I don't think they've actually they didn't at least think they had the opportunity, but this really gives them an opportunity to be involved. And the women's section is really off and running with a great program in the last round. So I think there is every opportunity to help support those sections. And Ken, maybe you can chime in on how, or Rupa, on how that can be done.
Ken, you're muted.
I'll hand it over to Ken.
Oh, thank you, Dr. Harris. So as I always say, I'm most brilliant when I'm muted. Thank you. Yes, the women's and the young surgeon sections are new organizations within the SVS. So like any new organizations, they themselves are going through the process of assessing their members' needs and desires, and going through strategic planning process for their program development. They're just about all the way through that process now. And so we are expecting before the end of this calendar year for both the women's and the young surgeon sections to have developed their robust list of requests or asks for programming for the next 3 years that we will then be able to communicate with industry partners and offer opportunities for various sponsorships and ways to collaborate. Needless to say, both of these groups are highly motivated, highly energetic, and they have a long list of things that they want to do. So I think there is going to be plenty of opportunity for us to do exciting things with both of these groups in the next 3 to 5 year horizon.
Joe, did you want to make a comment as well? You type something in the Q&A.
There was a question also about micro-learning. So that to me offers a lot of opportunity for partnership. So a lot of the younger people want to learn in small pieces rather than have longer sessions. So I could easily envision sessions focusing on different technologies or comparing technologies, such as, for example, intravascular lithotripsy or different atherectomy devices and how they work and what the potential pitfalls are. That could be the kind of thing that could be put together. We're hoping to do that so that we have them live, but also available as part of our educational platform for people that can't attend. There's lots of opportunities to do that. I can't speak for the women's group, but I'm sure they would welcome. There was another question about opportunities for industry to work with leadership development. I'm sure that could be worked out too. We're basically trying to make sure that we represent all our members and not just say that, but do it. And especially our younger members, because they're the future of who's going to have this job when we're all gone. So we really want to promote them and give them an opportunity to participate in the meeting and to learn and have the society be the place they go to for that kind of stuff.
Linda, maybe you could chime in a little bit about what micro learnings are, or at least how they're envisioned.
Absolutely.
Yeah.
So micro learning is basically a multitude of different opportunities to learn something in a very short time period. So under 10 minutes typically. Most of the time, what we have grown up with is hour-long lectures or webinars that are very long. But the problem is most of us don't have the time to engage in that activity on a regular basis. They can be things like the visual abstracts. They can be podcasts. There are a whole host of different things that can be packaged. So yes, this is an area where we can work with you because we're just learning how to get that out to people. Ideally, we'd have 5 to 10 minute little podcasts or visual abstracts that could actually be pushed to our members based on their requested areas of interest. So I might have one area of interest and Dr. Jolsing might have another. And if we sign up for something, we might have a push go to our phone on an app, ideally down the road, or it can be something that we go to the LMS and look at. There are multiple different ways of getting at that, but helping us to create content or develop platforms to deliver that content would be amazing. So that's what the micro learning is. And we're just new at getting into it. We're learning how to do this. This is not the way we learned, but it's the way of the future. And one example I've given that everyone usually chuckles is when you're waiting for your operating room, which is supposed to start at 7:30, it never does. You're happy if you start at 8. All of us would be happy because we're sitting there with our little cell phones to turn the cell phone on and watch a 10-minute podcast or something like that, but we don't have time for the hour-long education. So that's where it really becomes great because it's portable, and it also has been shown to increase retention you get multiple micro-learning, and they're going to retain that much longer than an hour-long lecture, where people's attention actually tends to wane after about 10 to 15 minutes. So micro-learning is really the wave of the future. I was also going to comment about the leadership development and speaking skills for women. Certainly, going to the women's section and making an offer there would be great, because some of the women have not learned speaking skills. This may also be something just for the young surgeons. If you wanted to have a session or help put together something, whether it's during BAM or outside through those different sections, that if people want to learn how to present, that might be an option to set up those type of courses. You'd have to ask the leadership in those groups if it's something that their members want, or if it's something they feel comfortable with already. But leadership development definitely is something that a lot of people do want.
Just another comment about the micro learning. I think our industrial partners are actually much more attuned to this, because I think they've seen that if you can't get to somebody in about a minute, or certainly less than 5 minutes, you'll lose their attention. They go to something else. And I think we're learning that as well. And if you do it right, you can really enhance everything else that's going on in their life. And I know that our younger members they're on their phone. We use a textbook, and now they're on their phone, and that's the way everything is done. So I think that's a big opportunity.
Right. So,
sorry, there was another question about opportunities for non-CME webinars.
Yep. What I was going to say, one thing we're trying to move towards is having a day a month of education, which we're pushing out. We've reached out to our regionals, and we'd like to include you guys as well. So all of our councils and committees know this. One of the problems right now is that we have meetings and webinars offered almost every single night. And you may have an amazing webinar that you want to offer, but if I've been on a webinar Monday and Tuesday and Wednesday, even if yours is the best of the week, I'm probably not going on Thursday or Friday because we're burned out. So the idea is to pick a time. We need to start coning in a little bit of our education so we're not overwhelming, and do it one night a month to start with. We may end up finding that we need to do a little bit more, but if we can cone into a time, we may also increase attendance, because if I go to the first session, maybe I'll just stay and watch the second because I'm already there. So if you have non-CME webinars that you want to do, this might be a way to partner rather than having them all separated.
Yeah, I think there's one other question: is support more DEI initiatives, and certainly we have a major interest in that, and there's so many opportunities. We're just getting started trying to figure out how to get past the point that we realize that there are these unrecognized issues that we all deal with, and then how to actually incorporate or bring it into our culture. So I think there is great opportunity here. Ken, you might have more specifics on what you might suggest, but I know that's a major initiative that we're doing, and we have for the last several years.
Yeah, thanks, Dr. Dalsing. Yes, I think the challenge for all of us in this arena is that anything we do that's going to truly be meaningful and make a difference is big. It's a big problem with a big scale set of solutions that take quite a lot of resources, and virtually nothing can be done successfully without significant cross-specialty collaboration. So what we really need, I think, first and foremost, is support from industry to help us be a convener and to bring organizations together to develop these collaborative visions and projects that we can work on together that could really move the needle and make a difference in these arenas. Our SVS Foundation has been focused on exploring through various pilot research grants the issues of how to close disparity of care gaps, particularly in underserved areas. And so this is I think a very fertile area of development and growth for us. Once we have identified pilots and delivery systems and models that might work, we're going to want to scale them up. and be able to get them into second and third tier testing and potentially reach more audiences. There are other programs that are more related to population health in this arena, such as the development of our supervised exercise therapy app and trying to move into research around wearables for patients and the transmission of patient data to their physicians and moving into the whole telehealth arena to close some of these gaps. And so there are plenty of projects here, and we actually need industry leadership to also be part of this dialogue with us to help us understand both the vision, but what is movable in the way of practical things that can move the needle so that we can all move this along productively. But this is a hot area that we really want to talk to industry about significantly.
Yeah, I also think it's an area that the industry is struggling with as well. We certainly see it when we talk to our regional societies because it's such a big topic that at least the regionals can't spend as much time with it. So they really are looking for some kind of leadership in that direction. So it is kind of one of those broader areas that the SVS really has to take some leadership in. And I must admit that industry also does the same thing. So I think we can learn a lot from them. And we certainly do need help in pushing this forward on many fronts.
And we've focused a little bit on the sort of the healthcare delivery aspects of this. I know there's a lot of industry partners that are interested to help us in terms of the recruitment aspects and advancement of careers for women and other underrepresented minorities within the field. And so, you know, I think there's multiple legs of this from the actual structure and culture of the SVS itself to, you know, the way that the vascular surgery workforce will look in the future to how we deliver care. And every single one of these areas has opportunities for us to move programs forward. So we would love to sit with industry and think through things that are win-win opportunities. But as I mentioned before, to really make a difference and move the needle, there needs to be a significant amount of resource and energy around these issues.
Yeah, I think the start of the session, Ken, has really made those opportunities even more evident, because with each new section, we get more and more potential projects, potential ideas to move forward. Sometimes it's hard to funnel everything into something that's controllable. So I don't think it's a matter of finding things that you can support in any one of these, in advocacy or education or DEI, just because there's a plethora of ideas out there, and if we have the resources to take care of them, we can do more. But that's what it takes. It takes a lot of resources. The volunteers certainly have the ideas, but we need the resources to really push them forward. I'm kind of you know, one of the major things that our industrial partners wanted to talk about tonight was advocacy, but I haven't seen a lot of questions in the Q&A on it, and I know that they have to be struggling with the same kind of issues with CMS and with the legislation and regulatory problems. Maybe they have a different problem in terms of device and how it's regulated, that kind of stuff, but still the same issues. So it's you know, it's something that we're always willing and anxious to have feedback from our industrial partners.
Dr. Dalsing, I'm wondering if either Megan or Matthew, if he's still on the call, would like to prognosticate a little bit and maybe talk to us about what they think might happen over the next couple of months and where we might find ourselves in January or February of this year.
Is that good ground for you, for Matthew or Megan?
I unmuted, but I was gonna defer. Yeah, there he is. I'm happy to take that,
Well,
but I'll give Dr. Seidemann a chance first.
I would say the simple answer is no. I don't want to prognosticate or speculate on that because I mean that's a near impossible thing to do. That's the frustrating and fun part of advocacy, is that it's always changing and you have to pay attention daily because it moves quick. But if you want my read of the tea leaves, I think that we're going to get some pushback from Congress about trying to get a third year of payment relief for physicians, but we'll ultimately pass that in some form or fashion. But we have found ourselves back in an annual cycle of fighting payment cuts, similar to the SGR days. And physicians are frustrated with that. I'm sure industry is frustrated with that. I know Congress is frustrated with that. So everyone pretty much believes that the current payment paradigm is broken and that we have to develop something new. Yeah, I'm just not sure what the time scale, the time frame will be for developing something new, and I think a lot of that will depend upon outcome of midterm elections and looming presidential election. Those always seem to kind of either speed up or slow down the process. On a side note, I was watching CNN this morning, and they were talking about priorities for the different parties, and healthcare was way down the list. So I don't really see that. With healthcare not being a priority, I don't see that playing in our favor for changing the system in the next couple of years. And I think we're going to have to get used to annual fights against systems that are going to keep pushing down reimbursement.
Yeah, Megan, you know, I know you're involved in multiple coalitions, and it might be interesting for this group also to know how you might interface with industry coalitions as well that might be working on these same issues.
Sure, that was actually the exact point I was going to add on Dr. Seidemann's comments. I think what we've all learned over the last several years, as we unfortunately get used to a hyper-partisan environment on the Hill, is that coalitions are more important than ever. And it can't just be, you know, a small subset of an industry working together. It really has become something much larger and more dynamic. And I think payment reform is actually a really great example of that. Because, you know, typically you would have the physician community working, and you'd have the non-physician community working, and then, you know, you may be engaged with the hospitals or, you know, partners in industry. And we've really tried to close the gaps between those groups. I think it's most evident in regards to physician and non-physician provider organizations, where really since 2020, when we saw the initial revaluation of the evaluation and management codes, we have been working in lockstep. And we've, you know, established a massive coalition that represents well over 1 million providers from a variety of specialties and practice types. And we have worked tirelessly to keep that group together and rowing in the same direction. And SVS has actually been a leader among that group. So, and we believe that's where we need to be, especially since, given the annual nature of the payment cuts and the areas of the fee schedule that have been most impacted, our vascular surgeons are among those that have been most impacted. So being amongst the leaders is exactly where we need to be. In regards to this specific point on industry, I think it's just been a matter of keeping those lines of communication open. a really nice example of that is in the clinical labor space, where a lot of our industry colleagues have been in touch with us, monitoring what we're doing and ready in the wings to support us in whatever way possible in terms of our communications and ongoing really negotiations with lawmakers on both sides of the Capitol. And so, you know, like I said, it's really collaboration is the name of the game. And as Dr. Seidemann noted, the results of this year's election will drive not only what happens in the next Congress, but what we may or may not be able to achieve in this year's lame duck session. And, you know, we are in a period of annual cuts. It is very remnant of the SGR years, but even with that acknowledgement, there's no way to get around the fact that we do need long-term reform. And so whether or not Congress wants to listen or not, we are going to continue that drumbeat, and SVS will be a leader moving forward.
I would just encourage all of our industry partners to make sure that your advocacy policy leads get in touch with Megan and make sure that the relationships there are built. Because we are all in this together.
Yeah, there's another question that's very interesting in the Q&A, and that's about the practice guidelines and the need to keep them current. And I think we realize that as well. And in fact, probably they should be living documents rather than transitional every 3 to 5 year documents or something like that. So I think that may be the way we have to go, but certainly the clinical practice guideline also takes significant resources and research, and each guideline really is predicated on how fast change is being made, I guess. But the clinical practice guideline is certainly high in our list of things to get done. And to progress every year. We just got done with the venous guidelines, just getting done. We got done with the chronic mesenteric ischemic guidelines, and I know we have and we had carotid guidelines that were just done maybe 6 months ago, which kind of leads into our how we can handle carotid disease from a perspective of management. So I do understand that that's really very important, and maybe some of the other panelists here can chime in and talk about clinical practice guidelines, AUC, anything else that you might want to bring up during this discussion. But it is interesting that we certainly do need that. CMS and a lot of other payers use these things to kind of see what's current in practice, so we do know that they're important. Elisa?
And one of the really interesting things where there's a nice crossover between the clinical practice guidelines and education is that we're going to be starting to produce micro learnings for the clinical practice guidelines, producing 10-minute videos, 5 to 10 minutes, that give really a high level overview of those guidelines and how to use them. So again, trying to disseminate the information in a variety of ways. Those are going to be forthcoming in the coming months. And another way that industry can help support is in the infrastructure of producing those micro learnings and disseminating those micro learnings.
Dr. Dalsing, there's a query about the joint SVS, SVM, APMA guidelines that are coming out of date. And we actually have a meeting with the leadership of APMA coming up this Tuesday. So I don't know if you want to talk about that at all.
Yeah, yes, we do have a meeting coming up in just a week. And one of the major agenda items was the clinical practice guidelines. I know that during COVID and maybe slightly before there was kind of a downturn in what could be accomplished, let's put it that way. But it's certainly resurfacing as something that we and they are interested in. And I know that SBM is also is always on our radar and involved with things that we do. So I think that we are in the process of rediscussing all these issues. And in a week, we'll be talking to the podiatrist and seeing what they have in mind.
Yeah, we started a collaboration with the APMA back in 2010. So there was a whole supplement that was jointly published, and we've published numerous things since then. We have discussed the diabetic foot and PAD guidelines, but there's right now an effort which you may not know about. So for the first time, the International Working Group on the Diabetic Foot, the European Society for Vascular Surgery, and the SVS are doing joint guidelines on diabetic foot ulcers and PAD. Those are going to come out in May. And then you also may or may not know the best trial results for endo versus open for chronic limb-threatening ischemia. Many of those patients are diabetic. They're going to come out on November 8th or 9th at the American Heart. So we've discussed this with the European group with Philippe Cole and Mark Schermerhorn, who's the head of the publications committee, that the timing to do this is probably early next year once we see what the working group came up with and what needs to be updated from there, and then what the results of the BEST trial are. And then basal is going to come out soon thereafter, which could alter the landscape a lot, actually. So it seemed premature to change a whole lot in the light of all that's going on, but that's on the radar.
That's a good summary, Joe.
Dr. Delsing, the other point of information, again, just for process and for our industry partners, is to know that every clinical practice guideline we have is in a queue to be reviewed every 5 years. So there's an automatic review. Once it's agreed that it is needing to be updated, that's what usually takes some time, because then you have to do the literature review, and you need to get the group together to determine the weighting or the level of evidence, et cetera, et cetera. So, but I do want to assure everybody listening that there is a regular scheduled routine review of all clinical practice guidelines every 5 years.
So there is a question about the VISTA programs in the Q&A. And maybe I'll let Joe start with this because he has one of those ongoing projects. And then Ken, maybe you can talk a little bit about name change and some other things that we're going to have to do with the VISTA program.
Yeah, so the initial projects met a lot of enthusiasm, both from the SVS membership and industry, both of whom kind of met and wanted to do something to expand vascular care to underserved people. So the first 3 grants were a little bit different, but related to that with PAD. So there's one from Misty Humphreys in Sacramento, looking at how to reach out to rural patients. One from Kelly Kempe in Oklahoma to look at Native American patients. And we have one in Houston to look at inner city people who are primarily Hispanic or Black. And so there was a lot of enthusiasm for generating even more studies. And the preliminary results of all 3 of those were presented at VAM in June, but they haven't quite completed yet. They'll all probably be finished in December. And then my understanding is we have another round of submissions. So we did want to change the process a little bit. So we thought the concept was good. We're working on a name change because the mission's changed a little bit. It's more about looking at ways to deliver care rather than actually doing it yourself, but coming up with people in the streets that are trying to reach patients where they are. And then we decided it needed to be a different committee. So it had to be a committee that was focused on reviewing grants. And we have a committee that's doing that. So we still think that has tremendous potential, and we do want to partner with industry. And I've met with some of you that are on this call as well as others. And there's a lot of interest in doing this because it's good for our society, it's good for patients, and it's good for industry if we can expand care to people who aren't getting it now, and care that they get is appropriate. And that's a lot of ifs, but we all believe in this, I think.
Mm-hmm. Yeah, I would say, and this is kind of alluding to the comments I made earlier, that this is our initial big focus here, which is starting to pilot solutions in the field that can be tested in terms of better care delivery models to close some of these disparity gaps that are out there. And so I think this has unlimited opportunity for expansion into innovative projects. But again, they're expensive and take resources and take some time. because what we want to do is stick to our values in SVS of following evidence and following science and doing a good job of taking these innovative ideas, implementing them, evaluating them, learning from the experience, and then the ones that really work, we want to scale up in a larger way. And we're almost to that point with the first 3 projects. As Dr. Mills said, we're looking at the next 14 submissions to see how many we can afford to fund going forward. And you know, I think there's just great opportunity for us to make a difference here moving forward.
Yeah, I think this is a big advancement from just recognizing the fact that we have these problems to actually having solutions for them. But it does take some time to get the data back to make sure that you're not spinning your wheels. And so you really do have to get some information back from the early grants and then consider what your next, where your knowledge gaps exist for the next grants coming through. So it certainly is a great opportunity though. And it helps us to solve some problems rather than just recognize problems. So there was a comment in the Q&A that industry would also support rolling updates on clinical guidelines, and that would be nice. We'd have to get a good process for that. And that also is resource heavy and time heavy. So
yeah, we've talked with some of the guidelines about having focused updates, because I've been on a lot of guidelines committees over the years, and sometimes you do a lot of expensive data analysis and find out certain things haven't changed. So it probably amounts to asking the right questions to look at key areas where there has been enough evidence that you can actually write guidelines that are more updated. So we've looked at trying to do that and make them more rolling. That takes work too, but it's less work than convening a big group every 5 years and getting systematic reviews and meta-analysis done. So that's very time consuming if you've been on those committees.
Dr. Mills, I wonder if a brief comment about the recent translation to guideline webinars for the global CLTI guidelines that you did would be worth a comment here, which is, it's one thing to develop the guidelines, it's another to get practitioners to implement them in practice.
Yeah, a slightly longer answer. So we've tried to put that into practice. So with the whole branding initiative I was part of a few years ago, we actually made up flyers that could be used by practices to put on their website or put in their patient information. We printed booklets of the guidelines. For the disease-specific modules we created, when there were guidelines that were applicable for patients or referring doctors, we put them on the back. So that was the first way we tried to do it. And then what Ken is referring to, and this was largely driven by John White and Riva Bouchon, but we put together a series of 3 webinars that kind of covered the global. So the global guidelines were published in 2019, and they proposed a couple. So the Wi-Fi system's 9 years old now, but the GLASS system, which is the new proposed anatomic staging system, and then this whole concept of patient limb and anatomy or plan, that's all relatively new. So how do you get people to use that in practice? So we had 3 webinars about 4 weeks apart, that covered, first was advances in medical care. So how do you make sure your patients are getting their risk factors modified appropriately? What role does the vascular surgeon play in that versus other doctors? The second one was on how you stage patients with chronic limb-threatening ischemia. And the third was on how do you apply that whole GLASS model with limb-based patency and target artery path and staging the patient and staging the limb in practice. And they were really well received. I think the last one had close to 200 attendees, which for a weeknight is phenomenal, I think. And so some of that could be broken down into micro learnings like Linda was talking about. And those are efforts I could see we could work with industry on helping us get some of those together. But we've really tried to, that's the first guideline that I can think of we've done that with. And I think we should try to do that with all our guidelines. And if we have timely updates as we start going forward, those would be ideal for those kind of mini webinars or series of webinars on updates?
Yeah, Joe, I was on those webinars, and they were not only they were international members as well, asking questions. So it wasn't just local members or U.S. members. It was from around the world. So it was well attended. And the medical one really gave the vascular surgeons the proper outlook on starting medications. I think people were really worried about statins, and you know what? It's something that you can easily start. The livers don't die, and you can really have a major impact on progression of disease and how it's taken care of. So those are great webinars. But I was especially impressed by the number of nations that were involved and the questions that were asked.
That went well. We had cardiologists, we had vascular medicine physicians, we had podiatrists, we had interventional radiologists, and each session had 4 speakers, and then John White and Mike Conti and I moderated each one and took a turn at who was primary, but they were really good, and the question and answer sessions were quite good. I thought they were excellent. We also did pre and post testing, so we're going to try to monitor how much of this gets retained and how much, if people don't know about the system now, are they using it in 3 months or 6 months, or do they just log into the webinar and check it off? So I'm hoping we can use that. I think that kind of thing would be huge for guidelines going forward, or for appropriate use documents where they can be controversial. So sometimes you can work through some of the areas like, why does it say that? I do this all the time. Well, you don't do it all the time. You do it rarely when all these other things happen, right? So kind of getting into the nitty gritty of them.
Yeah, communication is always so important, isn't it? If you talk to people, a lot of times you can answer questions that otherwise would be extremely controversial. So it gives an avenue for that. So there is a question. Let's see, if we publish a list of topics for the webinars that interestee can choose from, will you publish a list of topics? We certainly will, and that that would be not hard to do. We can certainly do that and get it out to this group, I'm sure, in short order. What do you think, Ken?
Absolutely.
Yeah.
And we would welcome industry's ideas too about topics that they would like to support. So it's a two-way communication.
Yeah, and it's in some cases it would even kind of help us to emphasize certain topics that we may not be at the top of our list and maybe at the top of your list. So it's yeah, it does work both ways, and we would certainly like the communication. Okay, so Joe, I think we did answer part of the DEI question, and I'm not so sure what I think the opportunities there are tremendous, and we've been given things to consider that are well beyond the resources we could ever do. So helping that area is truly desirable, and it's such kind of a new area for the medical field that there isn't a lot out there to guide us. So I think when we do things, we kind of we take a good trial as best we can, and then we see how the effort's done, and then circle around and try to improve. So it's kind of like that wheel of improvement that people talk about. I think that's what we're in with DEI now. Although, Ken, we do have some consultant experts that help us kind of work through this, and so I'm sure we're willing to share with industry some of the thoughts about DEI that we're gathering, and I certainly, and I'm sure you would love to hear what issues industry is facing and how they're taking care of it.
Yeah, that's why I'm feeling like we're heading toward a summit of some kind, building from the regional summits, Dr. Harris, that maybe we should have an industry summit where we could really share data and share vision and information around this issue.
I think that's a great idea. I think, you know, and you hate to say in person, but I think in-person summits for these type of activities can be very worthwhile because we're all trying to move in the same direction and we can lean on each other for where success has occurred and where failure has occurred, because we don't want to repeat the same mistakes. We're all trying to get things done in the right way, but we're all learning.
Yeah, Linda, I'm sure that in person would be better because I think you can, the exchange that you can have is so much better. So I'm sure if we can put together a summit in you know, with industry, with these questions in mind. And as we've done with our strategic board and with the EB now, we try to propose focused questions that can have a definite solution, or at least a way ahead, so that we kind of have a roadmap or a benchmarks for where we're going next. That seems to work well. I think business does it a lot in that regard with an SBAR type process. And so I think maybe that would be something that we can put together, especially if industry would want to partner in that kind of thing, provide us ideas.
Absolutely.
Yeah, I would venture to say that for those that will be in New York at the VEITH meeting, anybody that wants to sit down and brainstorm about this and maybe share some ideas about everything that we've talked about this evening and broadening the relationships with the SVS, we're very open. There'll be many of us there wandering around, and so we'll be happy to sit down with you and talk through your ideas and continue to bring the dialogues forward.
Yeah, and we even have a room there to sit down and talk. So it could be arranged not without too much difficulty in an environment where hopefully we could exchange ideas openly.
Rupa, I know that you and your staff are actively reaching out to all of our industry partners to, make a list of those opportunities. So.
Absolutely. We're happy to follow up after this call, and we're working on getting those meetings set up in the next few weeks. Dr. Dulce, do we have any more questions?
No, we didn't have any until right now. It said, "Is this recorded?" Will we make this available to others from our company who are not able to make it today?
Yes.
Go ahead, Rupa.
I'm happy to answer that question. Yes, we are recording this, and yes, we will make it available to everyone after this town hall is over, probably tomorrow at the earliest. And we will also follow up with each and every one of you to get your thoughts and feedback on how today's session went. So if we don't have any more questions, I guess we can wrap up if that sounds okay to everyone. And we're happy to take any questions even after this town hall is over. So please feel free to reach out to any one of us if you have any questions. We're happy to answer anything that you might have. Well, with that, I just wanted to say thank you to all of our panelists and our guests for joining us tonight for our first town hall. We really enjoyed having you in this discussion, so thank you so much, and we'll give you a few minutes back this evening. So thank you again.
Yeah, have an excellent night. And thanks for joining us.
Thanks, everyone.
Thank you very much. Appreciate it.
Bye.
Okay. Good night.
Good night.